we can find this symptom in case of the 1 minute. We can find this symptom in case of the investigation of the pancreatic stones and in case of investigation of the urological stones. The same symptom of the distal acoustic shadow we can find in case of the metal objects in the body of the patient. For example, if there's some constructions according to traumatology, and it's the it's some, for example, bullets, metal bullets, and ultrasound investigation, and very good ultrasound investigation is very good control for removing of the metal objects from the subcutaneous tissues.
Presented with right upper quadrant pain, and here's a video clip from.
One moment about the formation of the stones and some words about the role of the gallbladder. The usual answer of the students about this question, about the role of the gallbladder, it's the, and explaining about this, about my question, it's the storage of the bile or accumulation of the bile. The volume, internal lumen of the gallbladder is too very small. It's only the 100 or 120 milliliters. And I need to repeat the production of the bile by the liver, it's 2.5 liters, 100 milliliters and 2.5 liters. It's and the role of the gallbladder is not the accumulation, it's the concentration of the bile, only the concentration. And the role of the liver is concentration and evacuation, the 100 milliliters of the concentrated bile to the duodenum after some minutes after the starting of the eating or drinking. Because the liver is not the device for the full production, it's the organ, and minimally we need to wait 30 to 40 minutes for the normal volume of the bile production by the liver. And this 100 milliliters of the concentrated bile, it's very important moment for the normal nutrition of the food after the stomach. From the stomach, this food going from the stomach to the duodenum. And concentration of the bile, is the real reason for development of the stones. The previous stage before the formation of the stones is the formation of the sludge. Sludge is very, very concentrated fluid, and it's the condition between the fluid and the stone. It's the like the toothpaste condition. So what's about the epidemiology of this question? The usual sex of the patient is the female. 80% of the patients with gallstone disease is the female patients. And the age of these patients usually more than 50, 45 years. The main reason for development of the stones is the menopause and decrease the very serious decrease the level of the hormones, the female hormones, decrease the level of the estrogen. According to this picture, we can see the presence of the sludge.
A patient who presented with right upper quadrant pain, and we see here the gallbladder in the middle of the image. Let's look towards the neck of the gallbladder.
And we can see the sun focuses in the future stones in the gallbladder.
And we appreciate a fluid level that's made up of gallbladder sludge. We see here that the gallbladder sludge is tucked in there towards the neck of the gallbladder, but we see crystals moving up towards the fundus and towards the body of the gallbladder. I'd like to make a couple points with regard to gallbladder sludge, and the first is that occasionally beam artifact can masquerade as gallbladder.
I'm so sorry. Can you hear the sound?
Yes, sir, can hear the sound.
Okay.
Bladder sludge. However, sludge is going to be defined as having a fluid level that is going to layer out with gravity. Also, remember that gallbladder sludge can occasionally cause symptoms of acute biliary colic and acute cholecystitis in patients, so it's not a benign finding. Here's a video clip from a young male presenting with right upper quadrant pain, and as we're looking through the gallbladder, we notice here a finding within the neck of the gallbladder. We see here a concretion of gallbladder sludge and also tiny gallbladder stones known as microlithiasis. Notice that the microlithiasis has a posterior acoustic shadowing due to the blocking of sound waves through the concretions of the cholesterol crystals. So, an interesting finding on the spectrum of gallbladder disease. Here's another video clip, again from a male presenting with right upper quadrant pain, and what we see here is a gallbladder in the middle of the image, and notice the layering out of multiple small stones on the back wall of the gallbladder. We see the characteristic appearance of a gallstone here. Notice it has a hyperechoic or bright appearance, and we can see shadows coming off the back as the sound waves can't permeate the hard cholesterol crystals. Here's a still image showing the classic appearance of an impacted stone at the gallbladder neck. Here we're looking through the lateral intercostal view, so we get a nice long axis view of the gallbladder. We can see here a gallstone that's located within the neck of the gallbladder. Notice that it has the classic bright or hyperechoic appearance, and we see the hard shadow, the blackout of sound waves posterior to the gallstone. Interestingly enough, as we rolled the patient around and inspected the gallstone failed to move, showing that it was impacted and the cause of the patient's biliary colic. Here's a video clip showing an impacted stone at the gallbladder neck, again taken from that lateral intercostal view that gives us those great long axis views of the gallbladder. We see the liver to the top of the image and the gallbladder inferior to the liver.
And what is the reason for formation of the distal acoustic shadow behind the stone? Distal acoustic shadow is the absence of the reflection, because the material of the stone, its cholesterol crystals, it's the full block for the ultrasound waves, and black color behind the stone is the absence of the information. The same problem we can find in case of investigation of the bones. For example, investigation of the liver through the ribs. We need to use the space between the ribs, parallel space between the ribs for detection of any parts of the liver.
Towards the neck of the gallbladder, we see a white hyperechoic gallstone, and we see the classic posterior acoustic shadowing. As we mentioned in Module 1, it's always important to look at the gallbladder in two orientations. Here we've moved the patient into the left lateral decubitus position, and we're looking from the subcostal plane. Again, we see the gallbladder stretched out inferior to the liver, and within the neck of the gallbladder, we see the hyperechoic bright gallstone, and notice also the posterior acoustic shadow. As we pressed down on this gallbladder, the patient had a lot of pain, confirming a sonographic Murphy's sign. Here we're going to change the orientation of the probe into a short axis configuration. The probe is located in the subcostal plane with a marker over towards the patient's right. Thereby we're cutting the gallbladder into cross sections so the gallbladder will appear as a circle on the ultrasound screen. We see here a gallstone, that hyperechoic area within the gallbladder lumen, and again the posterior acoustic shadowing confirming the presence of a gallstone. Here's a video clip taken from an elderly patient with acute right upper quadrant pain. We're scanning back and forth through the gallbladder. This view is taken from that lateral intercostal view. And we see here the presence of multiple shadowing gallstones within the lumen of the gallbladder. So the end result of cholesterol.
But these big stones is not the problem for us, except the two situations, except the development of the Mirizi syndrome and Bourret syndrome. I will explain this material later.
Deposition within the gallbladder, forming multiple stones within the gallbladder lumen. And we can see here as we scan back and forth the multiple hyperechoic foci with a posterior acoustic shadow. Here's an interesting video clip from another patient with a
But this variant is the variant of the small stones. It's the real risk for the translocation through the cystic duct into the lumen of the common biliary duct.
acute right upper quadrant pain, and we see a distended gallbladder stretching across the screen here, the fundus located towards the right, and the neck over towards the left. Within the lumen of the gallbladder, we see multiple gallstones layering across the back wall of the gallbladder, and notice that they have almost like a small pea-like type appearance. And we can see also the posterior acoustic shadowing as we scan back and forth through the gallstones. So, multiple gallstones within a distended gallbladder. A sonographic finding that can be seen with a gallbladder that's completely filled with stones and in a contracted state is the wall echo sign. And here we see an example of the wall echo sign, long axis to the left and short axis view to the right. What we see here is the gallbladder filled with stones, and all we see is the anterior wall of the gallbladder, the echo from the concretion of stones, and the shadow off the back of the stones making the sign. Thus, the wall echo sign, pathognomonic for a gallbladder completely packed with stones and in a contracted state. And it can be occasionally difficult to find the gallbladder when all you see is the wall echo sign. One potential pitfall in performance of right upper quadrant sonography is that occasionally a loop of bowel may come right up against the wall of the gallbladder and be mistaken for a gallstone. Let's take a look at two video clips that show the difference between these two appearances. In the video clip to the left, we see a loop of bowel that's right up against the posterior wall of the gallbladder. Notice that it has a bright or hyperechoic appearance that could be mistaken for a gallstone. However, the loop of bowel is clearly outside the gallbladder wall and not inside as a gallstone would be. Also, let's look at the shadows that come off the back of the air-filled bowel. What we see is that there are dirty shadows, as I characterize, that are not completely dark as those that would be seen off of a gallstone. Notice that there's areas of white within the dark areas characterizing a dirty shadow. Let's take a look at the video clip to the right, and what we see here is an impacted gallstone at the neck of the gallbladder. Notice that it has a hyperechoic appearance that shadows, and that the gallstone is clearly within the lumen of the gallbladder. And we see the shadow that comes off the back is a clean shadow, completely dark, without those light areas that characterize air shadows. My conclusion points for this Soundbites module going over part 2 of bedside ultrasound of the gallbladder. Hopefully through this module you now understand the ultrasound imaging findings in the spectrum of gallstone disease that may be seen in patients presenting to the emergency department with abdominal pain. I hope also that you can identify the presence of biliary sludge or microlithiasis that can be seen as the first finding is of deposition of cholesterol crystals, on to the identification of large gallstone concretions. And last, I look forward to seeing you back as Soundbites continues and as we go on to gallbladder sonography part 3 that will focus entirely on the ultrasound. Go on further on our discussion of diagnostic finding department are going to be calculus or associated with cholesterol gallstones. While acalculous cholecystitis does exist, it's rarely seen in the emergency department, usually seen in patients who have been hospitalized, those who have had surgery recently, or those who have immunocompromised states such as HIV or diabetes. Acute cholecystitis is usually caused by obstruction of the cystic duct by a gallstone resulting in pathology, and the list of sequelae include gallbladder distension, gallbladder edema, infection or acute cholecystitis, ischemia of the gallbladder wall resulting in necrosis and perforation of the actual gallbladder. What are the clinical signs of acute cholecystitis that we're examining for at the bedside of the patient with acute right upper quadrant abdominal pain? Well, the primary diagnostic ultrasound finding is going to be the presence of gallstones with a positive sonographic Murphy sign, or tenderness over the gallbladder with pressure down on the ultrasound probe. These findings have a 92% positive predictive value for acute cholecystitis as found in this article by Dr. Rawls et al. In Radiology. It's an older article from 1985, but one that's often mentioned on discussion of acute cholecystitis. Now, there's multiple secondary signs of cholecystitis that we should go through, and these include a distended gallbladder greater than 10 centimeters in length, a thickened gallbladder wall that's usually mentioned as greater than 3 millimeters in width. Also, one may be able to see fluid in the gallbladder wall or edema within the gallbladder wall, as shown by a stripe
The fluid not in the gallbladder wall, it's the fluid between the layers of the gallbladder.
of fluid within the wall. Also, we can have pericholecystic fluid or a line of fluid outside the gallbladder wall as a result of inflammation or early perforation. Now, the presence of these secondary signs of acute cholecystitis does improve our diagnostic positive predictive value, but only increases the yield from 92% to 95%. So it's really most important to look for the primary diagnostic signs of acute cholecystitis. Here's a video clip from a patient who presented with right upper quadrant pain and fever. And as we look at the gallbladder, the first thing we see is the presence of multiple gallstones within the neck of the gallbladder. Also, we're going to examine here the anterior wall of the gallbladder, and notice with the small
The presence of this shadow, this black line,
indicator
black, this black
arrow,
line
I'm just
between
pointing out
the
that anterior wall.
layers
Notice
of
that
the one minute, please.
gallbladder.
Between the layers of the gallbladder wall is the information about the damage and usually necrosis, the death of the epithelium of the gallbladder. And it's the indication only for the surgical treatment. Because without this symptom, we can use the percutaneous draining, we can use the antibiotics, we can wait some hours or days before the plain operation. According to this variant, we can talk only about the acute urgent surgical procedure.
Also, we're going to examine here the anterior wall of the gallbladder, and notice with the small indicator arrow, I'm just pointing out that anterior wall. Notice that it appears thickened. Now, here I'm just indicating the posterior wall of the gallbladder, and notice that it's difficult to measure the posterior wall due to an artifact known as posterior acoustic enhancement. The sound waves race through the gallbladder, making it difficult to measure that posterior wall as it lights up. Here we're going to put calipers down on the anterior gallbladder wall, and notice that we have a measurement of 4 millimeters, indicative of a thickened gallbladder wall as we defined prior in the last slide as greater than 3 millimeters in width. This is a video showing two views of the gallbladder taken from a patient with right upper quadrant pain and fever. We see long axis to the left and short axis view to the right. This shows that it's important to image the gallbladder in both long and short axis configurations, as I think on these two video clips that the gallbladder wall anteriorly is better seen on the short axis view to the right. And we see here a concretion of gallstones within the gallbladder lumen and a thickened anterior wall of the gallbladder. This patient also had a positive sonographic Murphy's sign. Here I'm going to still that last image down of the gallbladder in short axis configuration, and we see the anterior wall of the gallbladder well delineated here. Notice the calipers across with a measurement of 9 millimeters, fulfilling the criteria of a thickened wall. This video clip shows another finding of acute cholecystitis. In addition to the multiple gallstones that we see within the gallbladder lumen, we appreciate a thickened
In a situation like this, with the presence of a serious defect in the epithelium and necrotic process in the other layers of the gallbladder, is the risk for the perforation and development of the perforative cholecystitis and peritonitis.
anterior gallbladder wall, and within the wall of the gallbladder we see a stripe of black fluid consistent with gallbladder wall edema. And here with the small indicator arrow, I'm just going to trace out that area of gallbladder wall edema within that anterior wall of the gallbladder. Interestingly enough, at surgery, the gallbladder was found to be very edematous, inflamed, and the wall was necrotic. Let's now inspect another video clip from an elderly patient with right upper quadrant pain and fever, and we see here on imaging of the gallbladder a distended gallbladder stretching out across the video clip here. Notice the large concretion of gallstones packed in at the neck of the gallbladder. But let's look closely at that anterior wall of the gallbladder, and we notice, as shown with the small indicator arrow, a stripe of fluid that is going to be pericholecystic fluid outside that anterior wall of the gallbladder. Now, the patient also had a positive sonographic Murphy's sign with a great deal of tenderness on pressure down with the probe over this gallbladder. So as we mentioned in part 1 of the ultrasound modules on gallbladder sonography, it's always important to look at a different plane on imaging of the gallbladder. So here's a subcostal view of the same gallbladder. We see again the multiple concretion of gallstones within the gallbladder neck as seen inferiorly towards the image here. Notice the shadowing off the back of the gallbladder, and we can see here the large stripe of pericholecystic fluid that is shown by that dark area of fluid that wraps around the anterior wall of the gallbladder. So, acute cholecystitis on bedside sonography. Let's wrap this module by looking at this video clip for the multiple signs of acute cholecystitis that are present here. First of all, we notice the distended gallbladder with a significant load of gallstones stretching across the posterior wall of the gallbladder. Incidentally, the patient had a positive sonographic Murphy sign, fulfilling the primary diagnostic signs of acute cholecystitis. Next, let's take a look at this video clip for some of the secondary diagnostic signs of acute cholecystitis. As we look at the anterior wall of the gallbladder, we see here that it's thickened and inflamed. We also see a stripe of pericholecystic fluid just outside the anterior wall of the gallbladder. So we see here some more of the secondary signs of acute cholecystitis.
Так, now 7-10 minutes for break, 10 minutes for break, and after that we should start it with the second part of our lecture, investigation and treatment of the post-cholecystic tonical syndrome.
Okay, sir.